Today we are going to discuss about lung ultrasound. Lung ultrasound can be used to image and identify pneumothorax and also other lung pathologies like pulmonary edema and consolidation and pleural effusion. So the best position for the patient to be in for the lung ultrasound is in supine position, and for the identification of pneumothorax we want to scan the anterior portion of the lung, and the best probe to use for the lung sliding to identify the presence or absence of pneumothorax is to use a linear probe. So here I am starting to scan the right anterior chest, and the probe position is directed to the 12 o'clock position towards the patient's head, and I'm placing the probe right between the two rib spaces perpendicular to the ribs. And as you can see on the ultrasound, we see two rib shadows here, and there is a parietal pleura line that is between the ribs right beneath the muscle layers, and you can see the shimmering of the pleura. And as I ask the model to take a deep breath in, you can see that there is sliding of the parietal pleura over the visceral pleura, and deep breath in and out. Yeah, as the model is respiring, you can see there is sliding of the parietal pleura right here over the visceral pleura, which gives rise to the lung sliding sign, and this is normal. And the other things that you see here are small vertical lines like comet tail shaped artifacts, which are called as Z lines. And as the lung sliding happens, you can see like 2 to 3 centimeter deep lines that are not going down all the way deep inside. And that is again the normal slide of the parietal pleura sliding over the visceral pleura. And that is the normal lung, which rules out pneumothorax. You want to do that on the both sides, anteriorly between the two rib spaces. Again, on the left side, you see here there is the rib and the lung sliding sign that's happening there. So the absence of the lung sliding sign means that the patient might have a pneumothorax, whereas you should be careful that the lung sliding can also be absent if there is like an endobronchial intubation, or if the patient is apneic and just not taking deep breaths. Like when I'm asking to hold the breath, you see there is not much of a lung sliding, but you can see the pulsations of the heart being transmitted, and there is some movement of the parietal pleura still, and that is again indicative of no pneumothorax. But right now, as you can see, there is no movement at all, which is a false positive. So the way to differentiate that would be to look for the lung pulse sign. Breathing. You can start breathing. Like the pulsation of the pleura with the heartbeat. So as you can see, the patient is starting to take a breath now, and you can see the lung sliding sign and the comet tail shaped artifacts coming back. Deep breath in and out. You can see the comet tail artifacts right there coming in and out. And then next thing to do would be to image in the M mode. The same thing. M mode, as the patient breathes, is going to show that deep breath in and out. Freeze. So here you see that there is a barcode kind of thing going on in the top, which means that it's a subcutaneous fat and tissue here. Whereas when the patient takes a breath, you can see it's like a sand at the seashore kind of thing. So that is normal to see this as the patient breathes in, and when the patient is not taking a breath in, you can see that the barcode sign that goes all the way down. In the case of pneumothorax, you're going to see the barcode sign there continuously throughout the respiratory cycle without the sandy seashore sign coming in. And that is another way to look for pneumothorax. The third way to look for pneumothorax is to find, when you image the lungs sliding sign, and then you trace all the way around the lungs to find if there is a lung point, which means there is no sliding anymore. And if you can find the lung point, that is indicative of that is very specific for pneumothorax.